My name is Paul Kidwell. I represent the Connecticut Hospital Association. You welcome my colleague Brian Knoyer earlier, and you'll welcome my other colleague Karen Buckley later. But wanted to take the committee's time on two pieces of legislation before you today. The first in support of SB 1450 related to workforce investments. CHA supports the legislation and the provision of loan repayment for full-time healthcare workers in our state. Certainly, hospitals are concerned about growing and retaining a healthcare workforce in our state. As was mentioned earlier today, many of those individuals finish schooling with substantial levels of debt for their education. I'm sure the Senator Anwar appreciates that. And loan repayment does help not only with those bills that come in every month, but also to help support all the other expenses that an individual is managing throughout the month. And so we support that effort. The other bill I wanted to spend time on today, and we must respectfully oppose, is SB 1452 related to physician affiliations. In our view, the bill addresses activities that are the fundamental responsibility of hospital leadership. The hospital leadership has an obligation to ensure that the hospital operates in a manner that best fulfills its mission to the community and provides for the best quality and patient safety. Oversight already exists in this manner. Hospitals are overseen by the Joint Commission, CMS, and also their own institutional boards. In our view, it's best to allow those with the whole view of the hospital's operation to make decisions related to how to staff and operate the hospital. We certainly acknowledge that those decisions can be disruptive and are occasionally and often implemented without full unanimity by those that those decisions will affect. Certainly, we support efforts to ensure that those decisions are made with minimal disruption, certainly to patient care and also to the individual workers that are affected by those decisions. We are, in closing, concerned that the bill creates another CON type process that will impede operational decisions by the hospital, affecting the quality of care delivered at our organizations. Again, I appreciate the time today to discuss these two matters with you and happy to take any questions.
Thank you so much. Thank you, Paul, for your testimony. And you know why the bill is written. The bill has the reason why it's written on everywhere in it. It's no secret that what Trinity did recently. One morning, they sent an email to everyone and saying the people who have been working there for 15 years, 120 some physicians, and saying that you join this for-profit entity or you're no longer going to work here. And that's outright abuse and wrongful action. We have to have mechanisms to, what happens is that there are individuals who are managing healthcare systems from outside of the state of Connecticut, and nothing good has come out of it. So, and I recognize as a CHA, you have to say what you have to say because you're looking at the greater good of every hospital. But there are some who have not been working in a manner that is appropriate from the state of Connecticut's values perspective, as I would put it.
Yeah.
So that's where the issue is. That the other thing is that every single hospital managing physician whose contract says that they should be seeing 18 patients, they're made for the whole year, they're being seeing 26 patients. So I don't want my family in that hospital to be treated that way. I don't want my family members who are physicians to be able to see patients in that manner because they will miss something. When you have an employer who has complete disregard for the well-being of the patients and the physicians, then we have to see bills like this and much more if I had my way.
So I appreciate the situation in which you're referring to, and I think respectively related to your concern around out-of-state organizations having an impact on patient care here in Connecticut. I think fundamentally the leadership of the hospital is responsible for the quality of care delivered by providers in the hospital and the quality and the safety of those patients. That's their fundamental responsibility and obligation. To the sort of legislative cure for the, I think, concern you've raised, and happy to talk about the specifics, but under the bill, a hospital wouldn't be able to make a change to its staffing model without first providing OHS with an application 180 days prior to when they wanted to make that change. And then OHS would have another 180 days to make the change. So you could have a year where a hospital effectively has lost control of its ability to manage how they're delivering patient care. We think, again, those decisions are fundamentally at the responsibility of the hospital and its leadership. And again, to your point related to quality of care and patient safety, there are already mechanisms and oversight with the Joint Commission, CMS, and survey and certification that fundamentally are created to meet those patient safety and quality goals.
So let's clarify this. If in this case, it's Michigan. Let's say Trinity is the case. Somebody from Michigan orders another individual who's the one person in the state of Connecticut who gets an order from Michigan, do this. And everybody else in the hospital administration and the medical staff, medical executive committee, everyone says, oh, this is not a good idea. This is not how we treat patients. And when the heavy-handedness of the Michigan organization says that you have to do this, then they reach out to the legislative branch of the government and say, can you imagine that this is happening to us? And then the legislators, when they see this and they actually do their due diligence, they realize that there is an outright abuse and danger to the patient's well-being. And so that's why the bill comes out of this kind, because the existing system isn't working. So legislation is following the multiple year long, but at least in the last year, far more progressive change that has happened in the patient care with not only the nurses, and for the ratios of the hospital, we actually around this body have decided about how the nursing ratios should be there because they are dangerous what was being done and we had to fix it. Not everybody was doing it wrongfully, but enough were doing it that it became a problem. Now we have 4 hospitals that have done this collectively through the order of Michigan Trinity branch. Now, with that in perspective, we as a body have a responsibility to address this. We cannot look the other way when our citizens, the most vulnerable in the state of Connecticut, based on the health physician shortage area, based on the medically underserved population, based on the medically underserved clinicians that are in this area, you actually look at those data from the federal government. The most vulnerable in the state are managed by these hospitals, and they're actually taking the care away. Another thing that happened was that the emergency room services, they remove all the emergency room physicians one day. Why it is necessary to have this 180 days is because if you suddenly say that the emergency room doctors have to leave or the clinicians have to leave, the patients who are going to be affected, whether it's in Waterbury or in Hartford, they would not have a place to go. And if they don't have a place to go, that's reduction in the services. And then the next thing that these institutions may do is they will offer a very low salary. So they say we cannot recruit, so we have to close these services. This game has been played in other states. I don't think we should play this in our state because when you reduce services to the vulnerable population, then we will stand up as legislative branch to speak out and say we have to have laws because the mechanism of how hospitals are operating, at least one hospital group is and actually 2, because if you look at what Prospect has done, again, managed from out of state, we are seeing a pattern which is dangerous for our citizens. So that's why we have to have these bills.
Yes, Senator, there's certainly no interest in hospitals trying to reduce services that are required for from the communities they serve. In the case of the emergency department, every hospital in Connecticut wants to make sure that their emergency departments are staffed appropriately, that people get care as quickly as they can. How those hospitals staff those departments varies across the state. In the best interest of those communities, that can be done through employed physicians. That can be done through affiliations with large group practices here in the state. That can be done through locum tenens. It's a number of different, through partnerships. There are different number of different models. Fundamentally, I think we share the same interest, Senator, is that the quality of the care we're providing is exceptional. I think that's what people in our communities expect.
I see Senator Gordon has a question. I could argue with you all day, but right after Senator Gordon, we'll have Representative Claire Dietra. Senator Gordon, you're on.
Thank you very much, Mr. Chairman. And if I dare, I would like to follow up on what you have so very well been talking about. If I may, I appreciate the Connecticut Hospital Association's input on this. And, in general, I'm not always a fan of having to use legislation or government oversight to achieve certain things that I would hope folks otherwise could achieve. But wouldn't you agree that if we were to allow hospitals, when there's these business decisions that get made that not only affect the ability of physicians and other healthcare professionals to provide the care that's needed to people day and night on a 24/7 basis, and also business decisions that we've seen where at times it can limit care, especially in rural parts of our state, by closure of various services, changing of staffing, things like that, which is really more and more the corporatization that we've seen over a number of decades, just not here in Connecticut. Wouldn't you agree then that when there are concerns more and more being raised about patients being able to access care and physicians and healthcare professionals raising concerns about being able to provide that care, that there is a legitimate role for this legislature and for state government to listen and to take a look and to see what needs to be done to protect patient care in Connecticut?
Senator Gordon, thanks for the question. Certainly, I agree that the legislature and the state of Connecticut have an interest in ensuring that care is delivered appropriately and that we have a healthcare system that is serving our residents. We have a very extensive certificate of need process in the state of Connecticut that to our mind, works probably too slowly, but is quite extensive related to the types of information that hospitals are providing to the state of Connecticut in order to see certain decisions are approved or disapproved. But this bill doesn't do that. It inserts, in our view, the state of Connecticut into the day-to-day operations of the hospital. Certainly, there is an obligation of a hospital with an emergency department to make sure that that emergency department is staffed appropriately. What this bill does is say the state of Connecticut is going to have a say in how that staffing model looks. And in doing so, the state will take into consideration certain things like the professional, financial, and personal well-being of the physicians being impacted. Certainly, these decisions do have those impacts on individuals. Those are certainly personnel or HR decisions. The bill also says that no physician may be terminated except for performance or conduct issues. That is going a step into how is a hospital managing the delivery of care, far beyond what is the current CON process. So I agree with you, Senator. The state does have not only an obligation, but an interest in making sure care is delivered effectively. In our view, this bill goes beyond that.
And thank you for the testimony. I will say I agree with you. Certificate of need process is broken and needs quite a bit of reform. And That's a whole separate thing that's being looked into and dealt with by the Public Health Committee. Mr. Chairman, I do appreciate you bringing up this concern and this item. I do share in the concern. I think certainly one can see what to do with different stakeholders, including the legislature's responsibility with regards to making certain that people are getting the care they need, when they need it, where they need it, but also the doctors and the healthcare professionals providing that care, given what we've seen go on and unfortunately continue to go on in various hospital systems. So I look forward to seeing what more we can do relative to this bill and addressing all the different concerns that have been raised. But I believe that a lot of the fundamental concerns that really are driving what needs to be looked at do remain and should be looked into, and I look forward to seeing what we can do in that regard. Thank you, Mr. Chairman.
Thank you so much, Representative Cleardis Teacher.
Thank you, Mr. Chair. Thank you for being here today. Thank you for your testimony. I'd like some clarification, I guess your opinion on a little bit of this bill. So as it's written, once a physician hits that 18 patients during that 12-hour shift, then that triggers the extra pay. But does it do anything with the patients in the 12-hour shift?
In our read, and thank you for the question. In our read, it was just manage the individual physician's compensation and would not impact the patient.
Okay. All right. So I'm concerned. I have my issues with this bill, and I understand that you do as well. But it seems to be focusing on physician compensation and not necessarily patient safety. Because if that's the issue, that we're having too many patients per physician, that seems to be a separate issue. So I have concern with that part of the bill, but then as far as you know, do any other states do this?
I'm not aware of other states, but I'm not aware.
Okay, thank you. Thank you for your answers, and I'll continue to look into this a little bit deeper. Thank you, Mr. Chair.
Representative Kristen McCarthy-Bay.
Thank you, Mr. Chair. Paul, thank you for being here. I listened in to the beginning of testimony. I'm glad to be able to be back here with you, and grateful you're here with us.
Thank you.
I'm going to go back to the first part of your testimony related to the student loan piece, and just reflect and ask for your thoughts beyond this bill. There are a number of different student loan reimbursement programs and bills advancing even in different committees in the legislature. And I know we've had some studies and conversation, and we have broad student loan reimbursement conversation. We have targeted, I believe, for nurses in higher education. I know the Appropriations Committee seeks to do some studying of this issue, and I bring this up here because even within our own committee, we had a number of task forces and working groups last year to look specifically, as you and I served together, at shortage areas. And I'm speaking in particular to our respiratory therapists, our rad techs, radiologic techs, and our nuclear medicine folks. So I wondered if you could speak to the shortage areas. You know, if you were waving your magic wand and writing the bill for us, what are the areas that you think are most in need in terms of that recruitment and retention for this effort?
And I appreciate the question. It's like choosing your favorite child, which as a father of two daughters, I would never do. I think number one, nursing. Nursing is the backbone of certainly the inpatient experience at our hospitals. The level of expertise that we require of our nurses is vast, and the hospital certainly would not run without them. No offense to our physician colleagues and or other disciplines, but I think an individual patient's experience often begins and ends with the nursing care they receive. And And we need such a broad set of skills from our nursing colleagues in order to provide good patient care. And certainly loan repayment is one part of the piece in how we attract people into our profession. And I think transparently in healthcare, times have changed. The post-COVID experience of many of our new graduates out of nursing school and other allied fields, their expectations are different than potentially previous generations. And so not only do we need to support things like loan repayment, but we're thinking critically inside the hospital field of how do we create an experience that is attractive to new graduates? How do we, given that there are more opportunities for individuals in remote work and telehealth, how do we make the inpatient hospital experience where you have to be, we need someone there, more attractive for individuals who are balancing very busy and chaotic lives? And so I think nursing, now I've sort of departed from your question, Representative, but I think nursing certainly is extremely important. And then I think, as you said, the task force are very helpful because it allows us to look at the data where we might be falling short in some of the allied fields. And and so certainly as we served on rad tech and nuclear medicine, respiratory therapy, extremely important. The other thing that we're considering is what is the support going to be like going forward from the federal government for some of these programs? And in many cases, those programs are targeted to certain areas. And so will that support remain into the future? And I think that needs to be part of our calculus going forward.
So if I may just follow up on that, one bill, we just JF'd the bill related to the Department of Public Health, which was the student loan repayment program that would allow them to receive HRSA federal
Right.
dollars and potentially other dollars. So I'm wondering if you can just reflect a little bit about some of the programs that you've seen that have been effective in working to help. As you said, it's one part of the bigger picture, but it certainly is, as we heard from in testimony a few minutes ago, I think it was right over $500 to $600 a month in that loan repayment. So if you can just reflect on what some of those effective programs have been, and also sharing in that where in the federal government or state government those monies have come from.
Yeah, so HRSA obviously it's probably the largest financer of the loan repayment programs, and I think not just here in Connecticut, but across the country, that those programs have worked effectively to target investments in areas of particular need. I think we're right to be cautious and or very mindful of whether those dollars will remain available into the future. So then sort of what does that leave us? And so certainly from the employer perspective, evaluating our portfolio of support for our patients and our employees, and what that support might need to be into the future, and what our capacity is to provide it. And then looking within the state budget and the mechanisms there, what is the capacity to provide any targeted relief for certain disciplines? I think that unfortunately, I think what the conundrum that you're probably getting at is that there is so much need, such a wide need for individuals and limited part of resources that I think we all need to evaluate going forward where those investments can be made. And do you spread a finite amount of resources across a larger portion of people, or do you try to focus in on a certain portion of people with greater resources? I don't know if there's a perfect answer to that. And it may be institution by institution. What do we sort of need in certain pockets of the state versus others? It's a question I obviously don't have a perfect answer to, but something we're considering.
And one more question, if I may, just to go back to our working group on the radiologic technologists, nuclear medicine, and respiratory therapists. I would just ask you to share what your own kind of key takeaways after we spend time in conversation about that were.
Critically important areas of care being provided at our hospitals, and I think my one takeaway is with additional resources and I think with the ability to recruit more students, our schools do have the capacity. We have really amazing instruction here in Connecticut in these areas, and we do have the capacity to expand our instruction if we can get into places where we can recruit individuals into those fields. And that may be straight from high school, that may be in our community college system. And then my second takeaway is part of the recruitment into those fields for those individuals who might want to explore additional opportunities in healthcare is a good way for folks to get into healthcare delivery and then understand what all opportunities may be available in the field. But I think my number one takeaway is we can create the capacity to train more people. We have to recruit those students into the classrooms.
Thank you. I appreciate that. So working together with our educators and those who are working with students in high school. I'm looking at Rep. Higgins right now. He doesn't see me. But yes, thank you. Thank you for serving on that task force as well. We appreciated that. Thank you, Mr. Chair.
Thank you. So Paul, I heard you correctly that you guys are in favor of 1450.
Correct.
Which is about retaining healthcare workforce, recruiting and retaining. So if your member organization, for example, we just heard from one of the person who spoke, Heather Broth, who mentioned that Bacchus Hospital, only 29% of the nurses could be retained and 71% just left over time, like a short time. And then that's one issue. Then APRNs in the emergency department for the Trinity, every single one who actually was working there, their contracts aren't being renewed, including the ones who had loan forgiveness program that they were part of. And the state of Connecticut was helping them, and the federal government was helping them for retaining them here in the state of Connecticut. But one of your members did not renew, then give them a short notice, and then they're going to be without jobs. And then that's all of the APRNs that are there in the emergency department. And the 120 some physicians were also we are trying to make policies, but we can't keep up with your members because they are not treating our healthcare workers in a manner that they would want to be recruited and retained in the state of Connecticut. So if you say you're supportive of this, then you have to have a mechanism to work with your members to treat the healthcare workers appropriately and not make the life of the citizens in the state of Connecticut worse. How can you help us with that?
Yeah, so respectfully, Senator, I don't think we make the lives of people worse. We're the largest collective employer in the state, over 100,000 employees, and our economic value to the state reaches double that in employment. So I think we make the lives of not only our workers, but certainly our patients better. However, as you noted, we always have work to do related to retention. Absolutely. I think every employer in the state wants to ensure that their employees feel valued and that the work that they do is important. And do employers get that right every time? Absolutely not. Do they strive to improve? I think absolutely. So we know we need to train and recruit the current and new workforce in healthcare. And certainly, as I noted earlier, Staffing models will change. I absolutely acknowledge that sometimes those have impacts on an individual's lives. Absolutely. Should those impacts be minimized? Absolutely too. Certainly, and if you're having loan repayment and that goes away from your monthly income, that's an impact on your family. I acknowledge that. But I think that our members, our hospitals in the state are striving to do the best they can for their employees and their patients. And that's a process of continual improvement.
Does the CHA have an internal mechanism to try and address some of these individuals who are hopefully outliers?
Oh, certainly our members learn from each other related to best practices. So we have groups of members that meet regularly to discuss, new models of care, new ways of doing things, their experiences across the state, many different affinity groups, so that individuals who are doing similar functions at the hospitals have an opportunity to talk to their colleagues across the state. We think that's one of the most valuable parts of being in the association, is that you do have the opportunity to learn from each other.
Perhaps there's an area of opportunity that we can work on to see if best practices are followed, because we cannot write bills when the employers, or the quote unquote the best or largest employer, as you would say, is not treating them right. And there's enough experience that's there that tells us that we can't keep up with our bills unless the hospitals and the larger employers are on board to retain those individuals and treat them in a fair manner. So I know Representative Claridge-Dieter wants another question. So Representative Claridge-Dieter.
Thank you, Mr. Chair. Actually, may have two, but the first one, do you feel the way this is currently written that this will trigger the notice of material change? As far as,
I hadn't actually thought about it in that context, related to whether this would be material change in our operations. I'd have to, if you don't mind, your indulgence, let me think about it, and happy to get back to you. But I think I agree with your point that we have to be mindful of what other obligations that this new one could trigger.
thank you. And my second question to that, with the physicians with the Trinity and then Vituity, is that,
Yeah.
I didn't say it. What percentage of the physicians have already signed on with them? If you
Sure. I understand from Trinity that 85% of the physicians have signed on with Vituity. Trinity, of course, would be best for up-to-date information, but that's my understanding.
Okay, and what was I had a follow-up to that. Okay, I don't remember what it was, but thank you.
Always happy to get back to you on anything.
Again, if a contract says that you're supposed to see 18 patients and you're asked to see 28 or 26, what's the recourse?
I assume in the contract, Senator, there would be an obligation for each party to oblige itself to actually meet the contract. And there would be a clause in the contract that would outline the obligations of each party.
Functionally, it did not happen for over a year. So I think again, you're in a difficult position. You're representing every hospital. So and you have to, by default, have to protect and speak for a bad actor too. But thank you for your testimony.
It's always a pleasure to be with you. We look forward to working with the committee on this and other issues. Thank you.
Thank you. Next person is Jane Presnick-Lyon. Welcome. Thank you for your patience with us today.